Alrighty, guys. So, welcome to Research in Health Psychology. So, to kick off this discussion, I want to highlight two different cases for you guys. One is of Daryl, who is a 30-year-old professional baseball pitcher, athletic guy, but at age 33, he dies of coronary disease. Case number two is Jim, who has been a professional runner all of his life, and at 52, he is a high-profile running guru who inspires the running craze in the United States. However, he also dies unexpectedly in his early 50s associated with coronary disease. So both of these cases are real. These are real kind of athletic influencers. But at the end of the day, if I were to ask you what conclusions can we make about exercise and cardiovascular disease based on these two cases, can we conclude that exercise is useless? You guys should all pretty easily be able to identify, no, that we couldn't do that. And that the reason we couldn't do that is because these are simply cases. We don't know if these are representative cases or if instead they are outliers. And so that is really where research comes into play. And I intentionally used kind of more of an absurd example earlier with, exercise being useless for heart disease, because you should all be able to kind of identify that and laugh because, we know there is very strong research to the contrary. But sometimes we find it more difficult to identify that anecdotes aren't a good way to make decisions about whether or not something is effective when the effect seems to be less ludicrous. And so at the end of the day, whether the takeaway from a particular case seems kind of insane or not shouldn't matter. We shouldn't really be presuming anything from one particular case. Instead, what we want to do is conduct a study to see how a group of people are doing, so we can really get an idea as to what an average performance or expectation is versus what might be more of an outlier that's not representative of the rest. So what we're really going to be focusing on today are research methods that are unique to health psychology. So I'm not really going to spend a lot of time on descriptive or experimental studies, but I do just want to kind of show this chart to highlight some of the differences in the event that some of you need a little bit of a refresher. So to summarize, descriptive studies are done in which we are basically kind of observing naturally things that happen and describing them. So we are observing that these two guys led very athletic and active lives, but still died of heart disease. Some strengths are that depending on the number of cases we're focusing in on, we might be able to really kind of focus in and take in some details about particular cases. But of course, the setback is that we're not manipulating anything, so we cannot infer causality here. We're not yet sure if the effect we think is happening, or if a third variable is instead at large. Experimental studies are typically done in some type of lab or more controlled setting where we are identifying the variable that we think is causing a particular outcome, and we are controlling and manipulating that particular variable to impact a particular result to, at the end of the day, make cause and effect based claims. So the methods that instead we're going to be focusing on today are quasi-experimental studies, developmental studies, behavior genetics, epidemiology, clinical trials, and meta-analyses. So quasi-experiments are kind of like experiments in nature, but instead of having an experimental group and a control group, we instead have two comparison groups. And this is because we're not controlling the groups in one way or another. These are natural groups in which people self-select into one group or another based on their natural inclinations. So this is kind of like a correlational study in a way, but it's just kind of stepped up a notch. And this is also typically an approach that's used when it would be impossible to take that additional step and to do a true experiment. So for instance, we could potentially do a quasi-experiment to address the research question, do natural differences in student exercise impact academic success? So we could let students self-select into an exercise or no exercise group based on whether they exercise or not. And we could keep track of their grades and see at the end of the day if there is any association or kind of trend between the groups. And again, many health phenomena are researched this way. Smoking is the example I always give, because at this point, due to the evidence that we have, we could not assign a group of people to smoke or not. We could do a quasi-experiment where we let people self-select as a smoker or a non-smoker, but we could not randomly assign. So we couldn't do a true experiment in that way. So the quasi-experiment is kind of a nice, I guess, plan B or a backup. A developmental study is another study that is unique to health psychology. These are helpful if we have a kind of lifespan research perspective, meaning that we're trying to answer questions about individual change or stability over time. So, do people become more conscientious as they get older, or do people smoke more or less as they get older? So any type of research question that's kind of relating to age or development. There are a couple different ways to do a developmental study. One would be to do a cross-sectional type of study. This would be a good approach if we were trying to answer the question of how does age affect blank? So how does age affect the frequency with which a person goes to the doctor? Basically with this, we would conduct a study at a single point in time, and we would recruit different groups of people based on their age. So we would recruit 10 25-year-olds, 10 30-year-olds, 10 35-year-olds, 10 40-year-olds, and 10 45-year-olds. We'd ask them how often they go to the doctor. Maybe we would track that information over a year, and then we would compare the results against those groups. So at one point in time, again, we're kind of gathering various groups of people based on their age. The biggest challenge to this particular approach is to keep everything else consistent. So to make sure that you've got approximately the same number of males versus females in the group, the same racial proportions, same SES, same education levels, to make sure that really the only thing that's different across the groups is age, which can be trickier in practice than in kind of just saying it. A longitudinal study is another approach. This is frequently considered to be kind of the gold standard or the design of choice as far as developmental studies go. And like many gold standards, it's very time and cost intensive. Basically, what you would do here is at a single point in time, you would recruit a group of individuals who were the same age. And you would ask or pursue whatever the research question is, and then you would follow up with them in 5 years and 10 years, 15, 20, 25, however long it is you plan for the study to go. So you're looking at the same group of people when they are 25, and then 5 years later when they're 30, and then 5 years later when they're 35, and so on and so forth. So this kind of addresses the challenge, I should say, of the cross-sectional approach, in that that everything else is the same across the groups because it's the same group just coming back at different points in life. The biggest challenge here, though, is dropout and attrition due to just kind of losing track of people. Sometimes people also die, the group isn't necessarily going to be the same because we can't control for what people do and whether or not they want to stay in the study. A final type of study is a successive study, which is a good way to assess whether or not birth cohort affects something. So for this study, if we were interested in how birth cohort affects attitudes towards smoking, we might ask a group of 30-year-olds at one point in time how they feel about smoking. And then in 5 years, we'll ask another group of 30-year-olds how they feel about smoking, and so on and so forth. So we're comparing 30-year-olds, but 30-year-olds at different points in time. So 30-year-olds in 2010 versus 30-year-olds in 2020, and so on and so forth. So we're kind of looking at more of a generational impact versus a purely kind of age piece. So that would be referred to as more of a successive study. Behavior genetics are another type of health psychology specific type of approach. These types of approaches evolved to help answer the nature versus nurture question. So how much of any trait or behavior is due to nature versus nurture? To answer this question, researchers will estimate heritability, or the amount of variation in a trait that may be attributed to genes. So at the end of the day, researchers may conclude that schizophrenia is 70% genetic, for instance, again, based on the results of these studies. Typically, the studies that are done are twin studies and adoption studies. Twin studies will compare groups of fraternal siblings or twins against identical twins to see what the similarities and differences are. And adoption studies will compare siblings and twins who stay with their biological parents versus twins that are raised apart from their parents, to see what the impact, again, of nature versus nurture is. I'd suggest pausing and viewing Twins, Is It All in the Genes, one of the videos that I have linked for you on As You Learn. It's a short little video that just kind of compares and contrasts these two twins who are middle-aged now, who grew up apart, and it's just kind of interesting to see the ways in which they're similar and different. And it kind of highlights the idea of an adoption type study. So at the end of the day, we can conclude that a trait is strongly genetic or heritable when identical twins are more similar than fraternal twins or normal siblings, when identical twins raised apart share a trait, and when adopted children resemble their biological parents more than their adoptive parents. Epidemiological research is used to track diseases. The origin of this particular approach is the 1850s, when Jon Snow, no relation to the Game of Thrones character, recorded cholera deaths in London. So cholera was outbreaking in London, and what he decided to do was to basically kind of take out a map and take note on the map where the outbreak was happening. And he observed that there was a 10-time higher likelihood of cholera in areas where the drinking water was polluted. And so from that, he could generate the hypothesis that maybe it's the water, and kind of test that out to see if that hypothesis had any validity to it and move forward with treatment. And so this is kind of basically how epidemiology works today, is the tracking of diseases to generate hypotheses, test them out, and plan interventions accordingly. There are several different measurements of health that relate to the field of epidemiology, one of which is mortality, which is the number of deaths due to a disease among a group at a particular point in time. We also have morbidity, which are a collection of statistics that are describing the living impact of disease. So these aren't people who are died, but these are people who've gotten sick or whose quality of life may have been impacted by getting the disease. So incidence is the number of new cases of a disease that occur in a specific population within a given time. And prevalence is the total number of diagnosed cases of a disease that exists at a given time. So mortality, overall deaths, incidence, new cases, prevalence, total number at a given point in time. And each of these numbers tells us something new. For instance, it can be important to attend to incidence when tracking a new disease like COVID-19, for instance. Are we continuing to see larger numbers of new cases, or are we basically just dealing with the number of cases that already exist? So it can be important to kind of practice seeing what these statistics look like. And what I have for you guys on the screen here is a typical representation of epidemiological statistics. Here we see the death rate due to heart disease by race and ethnicity in 2006. And you can see that women and men are separated. And then specifically, we have these kind of bar graphs for each particular racial group. So if I were to ask you, which group here is being impacted most by heart disease, you could clearly point to African American men on the basis that that particular bar graph is higher. A couple things to point out is that this chart is labeled death rate. So we can conclude that these are mortality statistics because mortality statistics relate to deaths. A second thing to point out is that the mortality rate of African American men is not 320.6, it is 320.6 per 100,000, which is a pretty common way of relaying epidemiological data. So the goals of epidemiology are to pinpoint the etiology or the origin of disease in order to generate hypotheses, to then evaluate those hypotheses and test the effectiveness of particular interventions, which I alluded to on the previous slide. So John Snow came up with his hypothesis about cholera. He evaluated that hypothesis, saw support, and then was able to test out the effectiveness of a water treatment-based intervention to prevent and treat cholera. In general, there are two different types of studies that can be done kind of under the umbrella of epidemiology. One is a retrospective study. We sometimes refer to this as a backward-looking study because that's what retrospective means. So with this, we would take a group of people with the disease and compare them with a healthy group to identify risk factors. So this is, again, basically what John Snow did, comparing people who had cholera with people who didn't have cholera to observe that the difference was polluted drinking water. This is also how we realized that unprotected anal sex and intravenous drug use were risk factors for AIDS. We looked at groups of people with AIDS and people who did not have AIDS, and two of the big factors that differentiate the groups were sexual behaviors and drug behaviors. Prospective studies are forward-looking longitudinal studies in which we begin with a healthy group and we follow that group over time, tracking those who continue to be healthy versus those who develop disease, comparing the groups as they separate versus looking at the separate groups and looking back to see where it is they separated. So this is the way that we figured out that alcohol consumption is associated with breast cancer development, is through regular checkups at an OBGYN office. We could kind of see over time that women who had lumps and were at a high risk for breast cancer, developed breast cancer, were more likely to be reporting alcohol consumption over the years. Also, under epidemiology is going to be the most complex category, I'll definitely say. So some other kind of mathematical equations, very simple mathematical equations that exist under the umbrella of epidemiology are relative risk and attributable risk. So these are some additional statistics that we can calculate to, in the case of relative risk, identify the likelihood of there being a causal relationship between a risk factor and an outcome. And in the case of attributable risk, which I'll introduce on the next slide, we're trying to figure out the public impact of a particular diagnosis. So here, we're kind of trying to estimate causality is a way to think of relative risk. So the way to do this is to basically construct a ratio of the cases within a risk group and compare that to the number of cases within a healthy group. So in this case, we would take the prevalence of cancer among smokers divided by the prevalence of cancer among non-smokers. So that would basically be 140 divided by 10, which would give us 14. So what does that number mean in English? It means that smokers are 14 times as likely to develop lung cancer as non-smokers. So one thing that I'd like you guys to calculate for us to discuss during our next class period is the relative risk of heart disease relating to smoking. So the relative risk of developing heart disease as a consequence of smoking. So calculate that and I'll give you guys the answer on Monday. Attributable risk, as I mentioned before, is kind of the public health impact risk, the public health impact statistic. So this is kind of telling us the amount of disease that can be attributed to a particular risk factor. So to calculate this, we take the number of cases within a risk group and we subtract the number of cases within the healthy group. So here that would be 140 minus 10 if we were trying to calculate the attributable risk of smoking relating to lung cancer, so that would give us 130. And again, in English, that would mean that for every 100,000 people, there are an additional 130 deaths from lung cancer in smokers. So we're looking at how many additional deaths or how much additional carnage is being caused because of this particular risk factor. So again, I'd like you to calculate the AR for heart disease here. So you can see that by comparing these data across these two slides, that again, these numbers are meaning different things. Heart disease in general kills more people than lung cancer does, and that's true whether or not you smoke. So we see that heart disease is going to have a larger AR number than lung cancer, but at the end of the day, the causal piece there is definitely more in favor of lung cancer, and that very few people who don't smoke get lung cancer, but large numbers of people get heart disease regardless of whether they smoke or not. Okay. So one of the last things I want to touch on is going to be the clinical trial and a meta-analysis. So the gold standard of biomedical research is a randomized clinical trial, an RCT. This is a true experiment where we randomly select participants, randomly assign them to experimental versus control groups, manipulate an independent variable to observe the effect in the dependent variable. These are generally conducted by epidemiologists following retrospective studies and other epidemiological inquiries to kind of test out hypotheses before you get to kind of this grand stage. A meta-analysis is a fancy kind of procedure that entails combining the results of many studies examining the same effect or phenomenon. So it's kind of like a study utilizing other studies as data points versus people. So rather than comparing like 50 people's, opinions about diet, you would instead combine like 50 studies that are all kind of examining that particular question to kind of see what the collective takeaway is. And at the end of the day, the interventions that we use are typically constructed from a long line of retrospective studies, clinical trials, or quasi-experiments if we can't do a clinical trial, and meta-analyses. So what happens when the gold standard isn't available? What happens in the instance of smoking, for instance? If we can't do the RCT and we're stuck with the quasi-experiment. At the end of the day, we can infer causality when the evidence is consistent. So across all research examining smoking and lung cancer, the evidence is showing smoking causes lung cancer. 2, the alleged cause is in place before the disease actually appears. So the person begins smoking and then they develop lung cancer, which is true. 3, the relationship makes sense. So smoking, we're taking something into our lungs, which is where the cancer is growing. So that makes sense. 4, there must be a dose-response relationship between the risk factor and the outcome. So in this case, the more you smoke, the more cancer, the quicker you'll develop cancer, the worse the prognosis. 5, the strength of the association between the alleged cause and the health outcome must suggest causality, aka there has to be a relative risk greater than 1, and the stronger the better. The relative risk of smoking with lung cancer is very high. The number we got earlier was 14, so extremely high. And 6, the incidence or prevalence of the disease must drop when the alleged causal factor is removed. So when people stop smoking, their risk goes down. When people stop smoking post-cancer interventions, the cancer is less likely to come back versus if they continue, it's more likely to come back. So the result of all of this is evidence-based healthcare, and the result is also why we can say that smoking causes lung cancer, even though we're not able to do RCTs to address that particular question. All right, so that's all that I've got for y'all on research. Talk to you later.